This is an EMCrit podcast. Today on the podcast, we have a fantastic guest, Joel Topf. And the reason I got Kidney Boy onto the show is there has been a debate waged in the nephrology world on correction rates for hyponatremia. Now, for a decade, we have been going super slow in chronic hyponatremia and super fast in acute hyponatremia. But there have been papers published recently demonstrating increased mortality with these slow correction rates when looked at in retrospective cohort studies and in meta-analyses of those same studies. Now, this is suggestive. It is not proven. This is not a demonstration of cause. It is a demonstration of correlation, but it is still worrisome. And it has led some nephrologists to say we perhaps should be using a quicker correction rate. And so I wanted to bring on an expert to discuss this issue. Now, for the first 10 minutes, we discuss some of the background literature. And then the last 20 minutes are all just purely clinical. So if you're like, I can't stand this evidence-based journal club stuff, then either just get through it for the 10 minutes or skip ahead, but don't abandon because it goes purely clinical towards the last 2/3 of the show. All right, quick message on a course, and then we'll get into it. Hey, folks, real quick, a mention of our upcoming course, Unburnable. You might have also heard me call this Flameproof. We've changed the name. It's now Unburnable. And we are having our fourth cohort. I can't believe we've done it this many times. Fourth cohort starting September 16th, 2025. And if you've heard me talk about this, you already know what it is, but really quick if you haven't. This is our virtual course that I host with my coaching partner, Rob Orman, on career longevity, anti-burnout, and self-mastery. Essentially, you will become unburnable at work. It will flow into your home time. You will be far more sanguine. You will like life more. You will start kicking ass. You will start wanting to come into your shifts rather than dreading it. Sunday nights will no longer be a disaster if you're working on Monday. It is 12 sessions, 2 hours each. We do every 2 weeks. So you're going to have us for 6 months percolating through your mind with topics like silencing your inner voice, your inner critic, agency and perfectionism, effective communication, shift overwhelm and efficiency, mindfulness and meditation, on-shift strategies to find joy, the fundamentals, things like sleep, life management and productivity, burnout prophylaxis, and then putting all of that together into a new system, a new strategy for enjoying work and life again. Everyone who has taken the course has given us positive feedback. For some people, it has been truly career-changing. And I think you at least owe it to yourself to check it out. If you are currently in the throes of the beginning or mid stages of burnout, then you should take this course. If you never want to get to any stages of burnout, you should consider taking this course. So just come to Unburnable Course. That's one word, unburnable course, because it's a course.com, unburnablecourse.com. Check it out. Look at the topics, look at the dates, see if this works for you. They're all recorded, so if you have to miss some of them, it's not a problem at all. You'll be able to watch the videos of your actual cohort and then still deal with all of the issues raised. There is a community that goes along with it. It's just friggin' fantastic. So if this interests you, come to unburnablecourse.com. All right, let's get to the show. All right, we're back with Joel Topf, EMCrit's favorite nephrologist, and he's kind of cheating on the Cashlack folks from Curbsiders, but I don't think they'll be upset. We're all friends. And Joel, I'm going to ask you some quick fire questions. Is the Earth still round?
Yes.
Okay. And does that said Earth still revolve around the sun?
Yes.
Then how, Joel, is it possible that what we're going to be talking about is all of a sudden we no longer necessarily need to slowly correct hyponatremia? In fact, it may be harmful. And when I first started reading these papers coming out of the nephrology world, my mind blown, and there's been retrospective observational trials, there's been meta-analyses, there's been warfare amongst the letters to the editor, there's all sorts of stuff flying. And Joel, what the hell's going on here?
Well, it's interesting that you listed all those different types of studies, but there was an important type of study that you did not include, You did not mention a randomized placebo-controlled trial about the speed of sodium correction because it has never been done. And some people will argue that it cannot be done, though last year at our national or international meeting, American Society of Nephrology Kidney Week, at their late-breaking clinical trials, they presented a trial that looked at two different strategies for correcting sodium, prospective randomized trial. There was no difference. They ended up not getting good separation in the groups. But to me, the important thing was this is doable. This is an answerable question with empiric data. We just need to have the will to do it. Interesting study still hasn't been published. That came out, that was last November, late October. And there is, and I know the study that I did we've had trouble getting these published, that there is a very entrenched belief in nephrology about how the sodium should be corrected. And you've been talking about warfare, and it seems to drag or slow publications down. And it's frustrating because we need to have an open mind with this. We can't be dogmatic with data that's lousy. And that's kind of, these clinical practice guidelines were really built on the basis of retrospective, just case series, and usually just case series of patients with the devastating osmotic demyelinating syndrome or central pontimyelinolysis, depending on how you want to call it. And it's frustrating because we need better data to answer this question. And I want to emphasize, I just actually did a big presentation on this, did a deep dive looking into all the data. And at the end, I came to the conclusion, we don't have the information. I can't tell you, I'm going to finish this podcast, so I'm not going to give you a good answer. I'm going to say, hey, the data's not great. There's a lot of questions here, and we really need better data to answer them.
Okay, Joel, give us some background on all of this.
Okay, so that's interesting. So if you, I want to go back to there's a June 12th, 1986 is this monumental date in hyponatremia. It's an issue of the New England Journal of Medicine. There are two articles in it. One of them is the introduction to the concept of osmotic demyelinating syndrome. This is the first article that really says, it's rapid correction of hyponatremia that causes central pontimyelinolysis. And then this is an important part of it, I think we are missing lots of the diagnosis because up to them, central pontimyelinolysis was only really diagnosed by autopsy because we don't have MRIs before then. We don't get MRIs to the early 90s. And this regularly doesn't show up on CT scans. It's just not a good study for this disease. And so Richard Stearns, who's still publishing on this stuff, says, I think we have these patients that have all the clinical symptoms of CPM. They get the bulbar pseudopalsy, and they get the locked-in syndrome, and they get the limb paralysis. I mean, he's exactly right. This is a disease. But he says, I say we can make this diagnosis without CT or pathologic evidence of this based on the clinical symptoms. Super important study. And there's another study that looks at acute hyponatremia, showing if you don't treat acute hyponatremia, these patients die. And this is postoperative women getting hypotonic fluids, horrible outcomes, really devastating stuff. So those two are there. And then there's a editorial by Robert Nairns, one of the great fluid and electrolyte teachers in nephrology, has an editorial on the same issue. And in that editorial, he says, you know what? I have never seen a case of CPM from rapid correction of hyponatremia. And I talked to 16 other nephrologists, and none of them had ever seen it, which is so funny because this is the same exercise I do when I give this lecture. I said, how many of you guys have seen CPM? And I'll have a room full of 100 nephrologists with, well over thousands of years of experience collectively. And there'll be one or two people that'll stand up when they've seen it. It is an incredibly rare diagnosis. I'm not sure if I buy that argument that we've seen a drop in this rate. I am skeptical of that. And I'll tell you, one of the interesting things, one of the best data we have, this is this Swedish study that looked at the rates of CPM in Sweden for 17 years. And when they did that, they found rates were actually going up, not going down over the 17 years that they looked at this. So this is Acta Neural Scandinavia, published in 2019. They divided it in 1997 to 2001, where they had a rate of 0.27. 2002 to 2006, rate of 0.62, and 2007 to 2011, rate of 0.9. This is per million, right? So this is incidence per million, this is literally, it comes out on average over that entire 14-year period to be about 0.6 per million. This is an incredibly rare diagnosis. So I guess I don't know of any good epidemiologic studies earlier than this. Are you aware of some, or is this just kind of hearsay? The interesting thing is that we don't get big comprehensive studies on this till starting in 2015, when people start to finally harness these EHRs and go beyond just, hey, we're going to get a case series of CPM and look at, hey, these are all the people with severe hyponatremia, and we looked at the outcomes. And so you can kind of look at the meta-analysis, and you can take a look at the articles there. The earliest one is George Hegan in 2015. That's Mayo Clinic. And that's when we started to see good comprehensive data that gives us a sense of the rate of this.
So tell us about this meta-analysis, Joel, because I think it encompasses all of those other cohort trials in there.
What I'd like to step earlier to the article that kind of broke it open. This article by Seethapathy. He's at Mass General, and he looked at all cases of sodiums less than 120 at Mass General and Brigham's. And it was 3,200 patients with sodiums less than 120, 57% women. Average sodium was 116. They found 7 cases of osmotic demyelinating syndrome. That's a 0.2% rate. And then if you looked at patients with sodiums less than 110, they had a 1.2% rate, 4 cases. So just over half of those had the most severe cases of hyponatremia. And then they divided rates of correction into 3 groups. And so the slowest group was less than 6 milliequivalents per liter per day. The middle group was 6 to 10, and the fast group was greater than 10. And then they broke it down. They had the most cases of ODS. They had 4 cases in that middle group, that 6 to 10, which is the recommended rate of correction, and then 1 case in the slow and 2 cases in the fast. But what separated this, and what I'm not aware that any other study had ever done, is they looked at hospital mortality as one of their primary outcomes. And what they found was that, that patients with hyponatremia had somewhere between a 10 and 30% hospital mortality rate. And they divided it by primary diagnosis, whether it was liver disease, heart disease, or cancer. So with the highest mortality rate, with 33% with cancer and 10% with liver disease, and 25% with heart disease. But when you looked at the 30-day mortality odds ratio of death, the highest rate of mortality was with that slow correction. So overall, the odds ratio of death was 2.13 for slowest correction, and for fastest correction, it was 0.69, with reference being that middle group. And this is the thing that just kind of popped everybody's eye open. Because if you look at the trend prior to this, every study said you need to go slow, right? And so in the clinical practice guidelines that came out in 2013, the Verbalis group, they recommended 10 to 12 milliequivalents per liter per day, unless they were at high risk for ODS, and then you should go 6 to 8. And then if you look at the review article on the same topic in New England Journal of Medicine in 2000, they were saying 8 millimoles per liter per day for everybody. Those same authors in American Journal of Kidney Disease in 2014 revised that recommendation. They said 6 to 8 now. And then Stearns, in his NEJM review article in 2015, said 4 to 6. And so you have the situation that, with nothing on the other side of the balance, with all the risk being just for fast correction, there was nothing pushing against going slower and slower and slower. And all of a sudden, this article comes out like, whoa, maybe we're seeing this differentiation in mortality based on rates of correction. Now, the thing that is essential to keep in mind is that there was not a difference in intention to the rates. This is just the observed rate. And almost certainly, the patients that were going slow were not because you had doctors meticulously measuring the amount of water and sodium going to the patient, but just patients had much more severe disease that was driving the hyponatremia and probably also driving the mortality. And the question, that's just residual confounding, right? You can try to do as much adjustment as you can, but you can't eliminate all the confounding. And I don't know, is it all confounding because of severity of disease? Or is there, at the bottom of that, some small amount of harm from slow correction? And with as rare as osmotic demyelinating syndrome is, when we're talking about 0.1%, Like it doesn't need to be much truth in there to outweigh the risk of ODS. And I don't think you're going to be able to answer this without prospective studies, without randomizing intention to treat, right? We're going to randomize patients in multiple rates of correction. I think that's what has to be done, but it hasn't been done yet. And the one study that was done, like I said, they didn't get good separation between the groups.
So now we have that trial. We have a meta-analysis, which that trial was included in.
Right. So, okay. Right. So that's the big one. Then Kinoshita was another large one, 200 ICUs all around the country, same exact type of results. That speed of correction, fast correction was associated with better mortality, slow correction with worse mortality.
What are we supposed to do with this, Joel? And I'm putting you on the spot as a clinician, but that's what you've always been willing to do, is tell us, like, all right, we need an RCT to really understand, and yet we're still required to practice. And so what are you doing in your practice right now?
So I think one of the things that's forgotten in those Verbalis American guidelines from 2013 is that the rate of correction was 10 to 12, which would be in all these studies, the fast correction group. That's what you can go. That's the speed limit, except if they are at high risk for osmotic demyelinating syndrome. They only had they had malnutrition, liver disease, alcoholism, and severe sodium less than 105.
Yep. And some of them have hypokalemia in them, and some of them don't.
Excuse me. And I would absolutely add hypokalemia there. And the other thing that I would add that I think is super interesting is in the Swedish study that I talked about earlier, massive study, comprehensive evaluation of all the cases of ODS or central pontic myelinosis in the country of Sweden for 17 years or 14 years. 88% of the patients that developed osmotic demyelinating syndrome had altered mentation on presentation, which is something which is all of a sudden I'm like, well, when I see that patient who's got that sodium of 112 and is walking normally and talking normally, and everybody's shocked when the sodium is so low, that is very reassuring to me. That puts them in what I would consider, unless they have other concerns, kind of low risk group. I thought that was super interesting, that evidence of encephalopathy on the outset. But and in fact, and that's also, if you read a lot of these case reports over and over again, the story is the patient was confused or having troubles. They get better as the sodium comes up. You think you're doing a great job, and then they decompensate later on. And so very consistent with the Swedish data. So what I'm doing is I am going 10 to 12 for everybody. And I'm being very strict by looking for these patients with high risk of ODS. And then I put the brakes on and I go 4. I go as slow as I can.
Okay, so let me make sure that I'm down with this. So for the group that has risk factors, you're going ultra slow. So 4, not even the 6, 4.
Yeah.
And is that in the initial day as well, or is that in subsequent days? Are you giving?
I do that to their sodiums. I really do it to their sodiums over 120. But I think I would probably relax it and not go full speed after that. I'd probably relax it a little bit, 6 to 8 after that. But I really think you need to go slow for those patients that are at high risk. The reason is it's my new hobby now, as I read case reports of osmotic demyelinating syndrome. And over again, every one of these case reports, you're like, oh yeah, there's the risk factor. There's the risk factor. It's remarkable. And maybe I should start reading ones without these risk factors and it would change my behavior again. But it just feels like you start reading the abstract and you're like, oh yeah, I know where this is going. I can see it.
Hey folks, we're just going to stop for a second because this is a free episode. I'm giving it to you in its entirety, but it's very rare that we have these full free episodes because EMCrit is a members only site that still has foam, but if you're enjoying this content, please consider becoming an EMCrit team member. It's inexpensive. You get CME. You could write it off on your taxes, but forget all that. What it's going to do is make you the best possible resuscitation and critical care doctor you could be. You'll have the most cutting-edge, up-to-date information, and you will get it in the comfort of your car or on the subway or while running, and you'll never have to think, am I current enough or not? Am I taking the best care of my critically ill patients? All right, let's get back to the show.
Right, I can see it a mile away.
Okay, and if they don't have those risk factors, and I'll say them again to make sure we haven't missed any, severe, less than 105, alcohol, hypo-K, malnutrition, liver failure, or you add altered mentation.
Add presentation would be another one that I think that I would add there, though it's not in the guidelines, because I think this is a kind of, this is an interesting one, but again, consistent with a lot of the case reports. If they have those, I get terrified and I go slow. And if they don't, I go 10 to 12, which ends up being, for these sodiums, if they're not 105, that means in a couple of days they're done. It doesn't take that long to get them fixed. And now I know, the interesting thing, which I think you were about to mention, is that the European guidelines say it's 10 in the first day and 18 over 2 days. And I think that's a reasonable thing to do also, to slow it down a little bit.
The other thing is that a lot of the patients in the meta-analysis were greater than 120 at the baseline. And, when they start, and that is, yes, it is hyponatremia. It's a different group. And in those patients, do you think we need to be scared if they're already 120 to start?
I think that a lot of them, it's not just that they went fast, they went too high. These patients end up with hyponatremia within a few days. And I think that's probably a bad idea. I guess what I would say is don't sleep on those patients, is that pay attention to them. It's real hyponatremia. When you think about this, is there anything more fundamental to homeostasis than a relationship between water and the body? This is one of the things that defines life in us. And there are so many important, strict mechanisms to maintain that sodium balance, maintain the amount of water in the body. And to think that, and sodium 120 is just nowhere close to normal, right? And so I guess this comes to two things. One, I can't believe, it's not surprising to me at all that it results in an increase in mortality. It's hard to believe that in the end, it doesn't matter how low the sodium is, right? It seems unlikely, right? If the body's spending so much energy and has so many mechanisms to maintain this, right? As the entire, the whole loop of Henle, the whole idea of being able to concentrate urine is all about being able to maintain the sodium. It just feels like, how could it not matter?
Let me make it a little tough for you, Joel. Let's say you had an alcoholic with a sodium of 121. Is that patient going to get 4? Or is there some kind of counterbalance now? What's your?
I'm probably going to go slow on that patient. I'm probably not going to sleep on that patient. I would be awfully concerned.
All right. Let's say you have an ED or ICU doc and they decide to go with what you're recommending, which I think is very reasonable and very supported. Are they going to be at risk if they just had that fluke CPM case and they were going at that 12 a day? They had none of the risk factors. They screened for that, and the patient winds up having it. Do they need to write something on their chart? Because when I do medical malpractice advice, I always tell people, it's not whether you miss or not. It's whether you showed that you understood you could have. If you said, oh, this patient is at a very low risk of PE, and I decided not to test because I risk stratified them and they wind up having a pulmonary embolism, you're pretty safe. You showed diligence. You showed you understood it could be. You thought about it. You demonstrated. It's the not showing you even understood. The lawyers want to be able to look at your chart and say, you didn't even remember CPM existed, right, doc? That was medical school. Last time you heard that one. Where on the chart is? So should they be writing something like, I've adopted for this patient, since they have no risk factors, a slightly relaxed stance. I'm going to allow them 12, but I understand the risk of CPM, but patients screen for it, and therefore I've deemed them at very low risk. Are you writing anything like that, Joel? How do you document your patient? You decide on that 12.
What I documented, I list out patient has none of these risk factors. Boom, 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 boom. And then I always say, this is my target sodium. This is what I want to be at this time tomorrow. And that's what I mean. Again, thank God I have never had a case of CPM, right? I am just so blessed. And I have seen a ton of patients break the speed limit. And it's incredibly common, right? I mean, you're looking at 40% of patients with sodiums less than 120 are breaking a speed limit of 8. Now, again, a speed limit of 8 is for people at high risk. So for a lot of those patients, they wouldn't be at high risk, but it's not a bad target to use to get a sense of what people are doing. People are breaking that speed limit all the time, and yet the rate of this complication is less than 1%, even in the people that break the speed limit. It's really a rare complication. Now, you start to pile on risk factors, rate goes up.
You say 40%. My experience is if they're not clamping, and most people still aren't, then that number has to be much higher in my experience, because I think it's impossible to not break that speed limit unless you're doing a DD AVP clamp. And Joel, that brings me to the next set of questions, which is the state of play such that we should just say this is standard of care? If you had your druthers, I know it's not yet, but I don't understand how to dial in any sodium value unless you're going to play the game of get what you get and then start giving them D5W and bringing it back. It's near impossible if they're capability of having aquaresis is still in play. So what's your feeling on the stance of this? I know we've spoken to you like 6 years ago and you were already very high on it. Everyone on EMCrit pushes this hard in their clinical practice. What's the state of play on the DDAVP clamp?
Yeah. So this is like also an amazing, again, I don't have a sense of how all medical procedures are adopted, but to me, it's kind of remarkable that we have adopted this unlicensed use of DDAVP to slow the correction of hyponatremia with no evidence that it prevents CPM. Like it's just been fully adopted. And I'm one of the people that adopts it. But it just feels like, boy, we're getting away from the way we're supposed to build medical knowledge, right? We're supposed to say, hey, this is a good idea. We should test this. And what we actually have is retrospective data saying, hey, people that get the DDAVP clamp seem to correct their sodium slower. And so, okay. And it makes sense physiologically. And boy, have we been burned on it makes sense physiologically over and over again. I do it, but I feel like, boy, wouldn't it be nice if we had better data? And the one that's even worse than this one is the re-lowering when we break the speed limit. We've got a little bit of animal data and this has been adopted and put into the clinical practice guidelines of something that we should do, recommended to do. I mean, boy, it makes me uncomfortable. But any of those patients, when I said I go by 4, I'm absolutely, the only way you go by 4 is by clamping them. Yeah, if you want to go slow, that's what you have to do. Now, if the rate is you're looking for 10 to 12 in 24 hours, I don't clamp those patients, not prospectively. I will start to treat them, see the rate of correction, respond there, right? Because I'm getting labs sodiums every 3 hours. And if it's going too fast, give them some DDAVP and give them some water.
All right. Joel, so far you've given us a very reasonable practice pattern here. We have our severe group and we're going to go super slow. We're going to be a little bit more relaxed in these patients that don't have risk factors. Is there any other nuance to this that we've missed so far?
Here's one of the things that concerns me is that we have substituted the concern for rapid correction with the concern for CPM. And to the point that's the only thing we've ever studied. Why isn't there any trial on the treatment of hypokalemia? Right? If this hypokalemia is a consistent risk factor, well over 2/3 of these patients have hypokalemia, and you start to think about potassium, that's interesting because if it moves into the cells, it's an intracellular ion, it should prevent that cellular dehydration. So it seems like giving them potassium would be a great antidote or protective against this, though there's the Edelstein formula that says every time you give them potassium, it raises the serum sodium. So it is something that you need to account for. And there's a famous case report on somebody who comes in with a super low sodium, a super low potassium, all thiazide induced, and they really give almost no sodium at all, almost no normal saline, just a few hundred cc's, no 3%, but they go crazy giving the patient potassium because you know how much potassium it takes when the potassium's in under 2. It just takes a ton. And the sodium just leaps up. It goes incredibly fast up, and they ended up with CPM. And so, boy, that kind of bakes my noodle. It doesn't seem to follow, right? That shouldn't cause cellular dehydration. In fact, it should really protect against it, and it doesn't. So that's something that really should be, it feels like it should be studied. We should have a better sense of what's going on, and it's embarrassing that we don't.
Well, I want to find out what you do in that circumstance. I clamp those patients, they're at risk, and then I just replete their potassium, and they get better at a very measurable rate. And I just think the amount of fluid you're giving with all those potassium riders is enough to cause massive aquaresis, and that's what causes their sodium to shoot up. So yeah, I don't give them any sodium. I clamp them, I give them potassium. Is that what you do as well, Joe?
That's what I do.
Okay,
yep,
great.
That's what I do. Because the patients that are hypokalemic, they automatically are the high-risk patients that you're going to go slow on. And so, yeah.
That brings up another question. There was a guy, I don't know if you've ever come across him because he's just an EM doc, but there was a guy named Corey Slovis who at every EM conference would give a lecture on hypokalemia in which he instilled into every emergency physician's brain that hypo-K equals hypomag. And he was the one that promulgated this more than anyone else. And as a result, every ED doc is always giving MAG every time the patient has hypokalemia. And then there was a retrospective trial published, I think 2 years ago, saying that there really was no connection. Now, it's retrospective. I'd love to see something a little bit more edifying. But what is your feeling on this? Are you still repleting magnesium with a patient with a normal serum level? because we were always told the serum level doesn't reflect whole body magnesium repleted anyway. And
then this paper went against
that. And there was never great evidence for the hypo-K, hypomag in the face of normal magnesium levels in the first place. Joel, put this to rest. Should we be giving empiric magnesium with a normal magnesium level in these patients?
I am quite skeptical of that. I have read the data. It is thin, but magnesium is among the most benign medications that we administer. Nobody gets in trouble from hypermagnesemia, right? Unless it gets unless it's, kind of a preeclampsia type picture. It's an incredibly safe medication to give. It's relatively inexpensive. I'm fine with it. And then I think the other thing to point out is that the things that do cause hypokalemia also cause magnesium wasting, diuretics, diabetes. Like it's not a hard stretch to see why they walk together. And so, but I don't really do a lot of the normal magnesiemic hypomagnesemia is something that I've read a lot about it. I wasn't convinced. The thing that I want to see is, rather than the association, is show me that not in a case report, but in a series of patients, that this replacing the magnesium actually makes things better. Patient-oriented outcomes. I've never seen that data.
Absolutely. All right. What else have we missed, Joel? Or have we really hit this where we need to?
So the one other interesting area is uremia seems to be protective against osmotic demyelinating syndrome. And so again, this is another population that gets a lot of hyponatremia, is the patients that have anuria from end-stage renal disease, because every glass of water just dilutes their sodium because they can't get rid of that water. And they seem to be more tolerant of rapid rises in sodium. I am not sure if that's ready for prime time. I'm not sure if that's something that I'd be willing to bank on that, but it does seem to be better tolerated. Because what happens is they get dialysis, right? Their sodium is 123, they get dialysis. In 4 hours, their sodium is 135, right? It goes up pretty fast with dialysis, and we seem to get away with it. You would think there would be a lot of dialysis patients that would be locked in, and doesn't seem to happen. And there's animal data to kind of support that.
All right. Joel, anything else we should hit, or are we good to go?
I guess the last thing is how many, the reflex that I see in ER doctors too often is they have hyponatremia, they're volume depleted. And it is such a dangerous place to go, because that bag of normal saline that is innocuous in so many patients can send that patient off to the races, and you can get this massive aquaresis when you give that, especially the thiazide-induced, the hypovolemic, if it's truly hypovolemic. And the one that really gets you into trouble is the tea and toast patient. Right? If it's a true tea and toast, that means they've completely suppressed their ADH. They should have a urine osmolality of about 50. So if you give them 1 liter of normal saline, they will turn that 1 liter of normal saline into 6 liters of almost pure water. Right? 300 milliosms of solute with a urine osmolality of 50 is 6 liters. And that sodium is going to go up so fast. And that tea and toast patient has malnutrition, right? They have chronic hyponatremia. And so it is a terrifying situation. And so I just get rid of that reflex, right, of seeing that hyponatremia and give them a liter of saline. It's benign in every patient except for this hyponatremia patient, where it can be really problematic.
That's the perfect place to end, because it's such a key clinical lesson. All right. Joel, cannot thank you enough. Kidney Boy, you are welcome to EMCrit anytime. You are beloved here, and I can't thank you enough for your time.
Scott, this was great. Thanks for having me.
All right, folks, there you go. Now, all of the evidence you want to see in the show notes for this episode, emcrit.org/402, as well as a infographic with the Kidney Boy Rex for correction of hyponatremia. But let's just go over them one more time, just in case you're not going to go to the show notes. And I would say don't start using these without a discussion with the nephrologist at your hospital. I think a meeting between EM, critical care, and nephrology, and just say, hey, let's make some standard operating procedures for hyponatremia correction in the hospital, and get everyone on the same page. But Joel's Rex, based on his reading of the best available evidence, is know your risk factors for being higher risk of osmotic demyelination. So that's a patient with a sodium of less than 120, and then any of the following: a super severe sodium less than 105, altered mental status on presentation, alcohol use disorder, hypokalemia, advanced liver disease. So that's super low sodium, alcohol use, hypokalemia, malnutrition, advanced liver disease, or altered mental status on presentation. If you have any of those high-risk features, super slow, 4 millimoles per liter per day until the sodium is greater than 120. It will almost certainly require DDAVP clamping to get a rate that slow. Patient with no high-risk features, 10 to 12 per day until the sodium's greater than 120. So there you go. If you have questions, thoughts, disagreements, put them in the show notes. Scott Weingart for the EMCrit podcast saying bye-bye.